So when we look at the nervous system, the nerves communicate to each other through what's called the synapse. So a synapse is kind of like a gap between the two nerves. And the way nerves communicate with each other are basically through neurotransmitters that will essentially get released at the synapse. So there's transmitter substances that do one of two things. They can possibly facilitate some sort of action. So in other words, when you have a facilitatory neurotransmitter, it depolarizes the postsynaptic nerve, which is the nerve that the first one is trying to communicate with. So some examples of facilitatory neurotransmitters, you have acetylcholine at the neuromuscular junction, and that's responsible for a lot of sympathetic and parasympathetic function. You have glutamate, which also does excitatory activity, which along with substance P and the dorsal horn of the spinal cord will help to transmit pain signals. So those are some examples of facilitatory neurotransmitters. Now you also have inhibitory neurotransmitters which block depolarization of the nerve. And these are instances where we'll want to use physical or pharmaceutical agents to kind of help assist with these in, again, modulating and reducing pain for the patients. So we have examples of these. We have glycine in the spinal cord, and we have GABA in the spinal cord and the brain. So both of these are inhibitory neurotransmitters that, again, kind of understanding how these work can inhibit and modulate the pain experience. We also have beta endorphins. So beta endorphins are basically chemicals that are opioid peptides, and they're called that because they basically bind to the same sites that opiate drugs bind to. So these are neurochemicals that will actually help to reduce pain. Beta endorphins are very large peptides, and they have a half-life of about 4 hours. So beta endorphins can actually help in pain reduction for a longer lasting time. There's some other neurochemicals that also do this. You have your dynorphin and enkephalin. Enkephalin's a real important one. It helps to block substance P at the spinal cord. Those have a much shorter half-life, but again, you can still kind of utilize them to help to get physical agents to kind of encourage them to do their work in modulating pain. So it is important to note that these endogenous opioids, they occupy the same receptors as narcotic medications. So if somebody is taking narcotic medications for chronic pain, it should be noted that the endogenous mechanisms are going to be inhibited. So in other words, if someone's taking narcotic drugs, it could possibly sort of reduce the effectiveness of the physical agents. So you kind of have to know that ahead of time. If you know you have a patient who's taking narcotic pain medicines, you may not be able to apply the certain physical agents, or it just might not be efficient, rather, I guess is a better way of saying it, because applying those physical agents in that circumstance would almost not be as beneficial to the patient because they might not get that response since they're already taking those particular pharmaceuticals. Okay, so getting back to talking about chronic pain, again, besides being pain that lasts beyond the normal usefulness as far as a specific time length, again, this is going to be different from persistent pain because, again, chronic pain, you're going to be looking at changes in the structure and function of components of the nervous system. So, in other words, your nociceptive system is going to kind of change a little bit. And essentially what you end up is getting this increased sensitivity to mechanical and thermal stimulation. So basically the system in as far as how our body will naturally kind of modulate pain essentially fails. Okay, so you get increased sensitivity. The descending pathway will work in such a way that there's increased pain sensitivity as opposed to doing what it should actually be doing is reducing pain. Okay, and essentially what ends up happening is you don't really get relief from modalities per se from true chronic pain. Okay, persistent pain on the other hand, you could kind of work the modalities with a little bit more. True chronic pain, it gets much more difficult when you're dealing with this. So your book kind of cites three potential sources of chronic pain and how it could happen. So these are just some different mechanisms. One is an upregulation of what we call silent nociceptors. So basically what ends up happening is the upregulation is basically influenced by previous pain experience. So here we're getting, again, what individuals have experienced in the past with pain and injury is going to, increase their sensation to pain. So basically what we're talking about here is you're getting increased signaling to the brain about this pain that's occurring. So there's that constant, again, feedback related to pain. A change in the chemical environment around the free nerve endings. So we had talked about in the chapter on tissue inflammation and repair how we do get these chemicals released. However, again, under most circumstances, that process kind of wanes down after a while, as long as everything's going as it should in treatment. However, in the case of chronic pain, you get this change in the chemical environment around the free endings where you're just constantly getting this increased noxious input into the dorsal horn of the spinal cord. So remember, the sensory nerves go into the dorsal horn of the spinal cord, so that increased noxious input keeps coming in, and you basically end up getting a lot of these inflammatory chemicals. What ends up happening is the pH in the area continues to go down, and the free nerve endings continue to get more and more sensitized to pain. So again, the person's just experiencing this. They call this change in environment. Your textbook is labeled it the inflammatory soup. So this inflammatory soup just describes a situation where these chemical mediators associated with inflammation along with lowered pH and sensitized free nerve endings just continuously produces this noxious input that the body perceives. And then another thing that is a potential source is a phenotype change in primary afferent nerves. So in other words, the myelinated nerves will take up the properties of unmyelinated nerves. So we talked about how A beta fibers transmit just general sensory information and touch. Okay, so A beta fibers classically don't transmit pain. However, in this situation, because of the abnormal noxious input, A beta fibers will actually start to transmit pain information. Okay, so where a nerve that classically wouldn't do that now will start to take on the characteristics of a pain fiber. More specifically, those type C, it'll take on kind of the characteristics of the type C fiber, which is your unmyelinated pain fiber. So it'll kind of take up that sort of property, and you'll start to get some pain transmission from that as well. And these are the various learning outcomes that you can kind of look over and review for the for any exam we would have on this information.